Welcome to Clinical Minute. Female Sexual Health. Prescription medication for Hypoactive Sexual Desire Disorder. Anna is a 28-year-old elementary school teacher who has been in a relationship for 1 year. She has used a hormonal IUD for 2 years. Anna presents today for a well-woman exam. She voices no concerns, but her responses to the pre-visit questionnaire she completed in the waiting room suggest that she is not satisfied with her sexual function because of problems with little or no interest in sex. What is your first step? According to the World Health Organization, sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. In 2016, the International Society for the Study of Women's Sexual Health agreed on nomenclature for female sexual dysfunctions. Based on Anna's questionnaire, you suspect that she may have Hypoactive Sexual Desire Disorder, or HSDD. HSDD may be primary or secondary to another condition, lifelong or acquired, and generalized or situational. Criteria for diagnosis require the presence of either lack of motivation for sexual activity or loss of desire to initiate or participate in sexual activity, along with clinically significant personal distress. This distress can take the form of frustration, grief, a sense of incompetence, loss, sadness, sorrow, or worry. The symptoms must represent a change from the previous state that has persisted for at least 3 months. Several psychological conditions and issues can contribute to HSDD. These include mood disorders or states such as depression, irritability, rage, fear, shame, and embarrassment, anxiety or lack of sexual self-confidence, sleep disturbances which can decrease psychological resilience, developmental issues from the past such as trauma, abuse, the impact of childhood illness or surgery, divorce, affairs, abandonment, or other experiences resulting in a lack of trust, and body image issues. Interpersonal issues can also contribute to HSDD. Some of these include chronic discord in the form of emotional estrangement or disappointment, ghosts of past relationships, which can lead to fear of making oneself vulnerable or negative expectations. Partner sexual problems, such as erectile dysfunction, rapid ejaculation, low or discrepant desire, or being sexually maladroit. And partner psychiatric illness, such as addiction or depression. In addition to psychological and interpersonal issues, medical conditions and medications can contribute to HSDD. Medical conditions include endocrine disorders, such as diabetes and thyroid conditions, neurological disorders, cardiovascular disease, and psychiatric conditions such as depression, anxiety disorders, and post-traumatic stress syndrome. Many medications cause sexual side effects that can contribute to HSDD. This slide lists some of these medications. The Decreased Sexual Desire Screener is a 5-item questionnaire to be completed by the patient. It was developed and validated to help clinicians diagnose HSDD in premenopausal and postmenopausal women according to criteria in the DSM-IV-TR and those developed by the International Society for the Study of Women's Sexual Health. The PLISSIT model can be a helpful tool for discussing sexual health or concerns with patients, and for planning next steps for screening and management. The model consists of 4 components. First, permission. Ask open-ended questions during the routine history to give the patient permission to talk about her sexual concerns and reassure her that her feelings are normal and acceptable. You could say, "Many women with menopause have sexual concerns. What about you?" Then use follow-up questions such as, "What do you mean by that?" or "Tell me more." Second, provide limited information. Provide education about female pelvic anatomy, the sexual response cycle, and the neurobiologic etiology of sexual problems. Discuss changes in sexual function throughout the life cycle. Explain that sexual interest or desire may not be the first stage in response. And explain that women may not experience orgasm 100% of the time. There are many topics to cover here. Address the most important ones in the time available, but don't feel pressured to cover all in one visit. Ask the patient to make a follow-up appointment to focus on sexual health concerns. Third, specific suggestions. Offer specific suggestions and solutions to treat the problem. For example, suggest the use of lubricant, over-the-counter moisturizers, or topical estrogen for dryness or dyspareunia. Suggest that she plan date nights and make sexual activity a priority. Suggest that she improve her diet, exercise routine, and sleep patterns to help overall mood. Fourth, intensive therapy. Consider referring the patient for intensive therapy to qualified sexuality specialists. Because a variety of general health and psychosocial factors can impact sexual function, a thorough sexual history must cover a lot of ground and must include both medical and psychosocial issues. Questions about medical issues should explore the items listed on the left. Questions about psychosocial issues should explore the items listed on the right. When a sexual concern exceeds a clinician's level of comfort or expertise or warrants intensive therapy, a referral to a qualified specialist is recommended. There are currently no testosterone products approved in the United States for treating sexual problems in women. The testosterone patch is approved in Europe for treating low sexual desire associated with distress in surgically menopausal women who are also on estrogen therapy. Studies have shown that testosterone delivered by skin patch increases sexual desire and the frequency of satisfying sex among carefully selected postmenopausal women with low desire that causes them distress. Common side effects include acne and increased facial and body hair. Dehydroepiandrosterone, or DHEA, is a natural hormone and is available as a non-prescription supplement in the United States. DHEA is an inactive precursor to androgens. Prosterone, which is a DHEA vaginal insert, was approved by the FDA in 2016 under the trade name Intrarosa to treat women experiencing moderate to severe pain during sexual intercourse due to menopause. Its efficacy was evaluated in 2 12-week placebo-controlled clinical trials that included 406 healthy postmenopausal women 40 to 80 years of age with moderate to severe pain during sexual intercourse. Prosterone, when compared to placebo, was shown to reduce the severity of pain experienced during sexual intercourse. The most common adverse reactions observed in these trials were vaginal discharge and abnormal pap smear. For DHEA supplements, which are not reviewed by the FDA, the evidence on effectiveness is mixed, and safety and efficacy data are lacking. This table lists centrally acting agents for the treatment of HSDD. These agents modulate neurotransmitters in the brain that affect sexual response in women. Bupropion is a norepinephrine dopamine reuptake inhibitor approved for treatment of depression and smoking cessation. It has been shown to improve measures of sexual arousal, orgasm completion, and sexual satisfaction when assessed using the Changes in Sexual Functioning questionnaire. The most common side effects in trials treating depression included tremor, agitation, dry mouth, and constipation. Buspirone is a serotonin 1A partial agonist used to treat anxiety. When used in combination with a selective serotonin reuptake inhibitor, or SSRI, it was found to decrease SSRI-related sexual side effects, with 58% improved compared to 30% improved with placebo. The most common side effects in trials treating anxiety included dizziness, nervousness, nausea, and headache. Flibanserin is a serotonin 1A receptor agonist and a serotonin 2A receptor antagonist. It is FDA approved for generalized acquired HSDD in premenopausal women. In 3 clinical trials, flibanserin was shown to increase sexual desire, decrease sexually related distress, and increase satisfying sexual events. Note that efficacy takes time to develop. If no effect is seen within 8 weeks, it should be discontinued. Its prescribing information includes a boxed warning that highlights the increased risks of serious hypotension and syncope with concomitant use of alcohol. Hypotension and syncope can also occur if taken with moderate or strong CYP3A4 inhibitors, including clarithromycin, ketoconazole, and others, or in patients with hepatic impairment. Certification is required for prescribers and pharmacies. The most common side effects in clinical trials included dizziness, somnolence, nausea, and fatigue. You begin a conversation with Anna about sexual health concerns with a normalizing statement followed by an open-ended question. You say, "It is my routine to ask about sexual health as part of the well-woman visit, and I noticed on the questionnaire you indicated that you are not satisfied with your current sexual function due to low interest in sex. Many women have similar concerns. Tell me about what's been going on." She says she has no problems with pain or dryness. She goes on to say that her desire for sexual activity decreased about 6 months ago, and she feels sad and very frustrated. You validate her feelings and suggest a separate appointment so there will be enough time to talk about the problem. You ask her to complete a decreased sexual desire screener for the next visit. You complete a routine exam as part of her well-woman visit, including a careful exam of the external genitalia. There is no tenderness on bimanual exam, and the speculum exam is normal. Because the history does not suggest a thyroid or pituitary condition, you order routine labs only. Anna returns 2 weeks later. The screener is diagnostic for HSDD. Upon further questioning, you learn that Anna has no history of past sexual abuse or issues in her current relationship. She continues with the hormonal IUD. You provide a referral to a counselor who specializes in cognitive behavior therapy for sexual problems and ask Anna to return in 6 months if HSDD persists. Anna returns in 6 months. HSDD has persisted. Having completed the certification process at addyrams.com, you suggest the possibility of prescribing flibanserin. You discuss the risks and benefits, including the need to avoid alcohol. You obtain informed consent and prescribe flibanserin. You direct Anna to a certified pharmacy to obtain the medication and ask her to schedule a follow-up appointment in 2 months and to contact you or another care provider if she experiences any side effects or has any concerns.